Everyone, welcome. So
Hey,
as
Richard.
everyone is enthusiastic about this talk, my name is Damilola Jolayemi, and I with the Center for Behavioral and Addiction Medicine, and I will be helping support this session today. So I will give a brief overview of what this series are. This is actually the first session of this series that we've been working on at the Center for Behavioral and Addiction Medicine with the Department of Family Medicine at UCLA. This session is called a Case-Based Learning Collaborative on Stimulants. And the objectives of this series are to use a case-based learning approach to share experiences, educate, and disseminate the latest evidence-based data on the use of medications and other therapies for treating stimulant use disorders, and to also generate a network of providers and provide the latest evidence for treatment of stimulant use disorders. This is actually a CME session, so you have an opportunity to earn CME credits if you would like to apply for those. This session actually is really structured in a way where there'll be a presentation by our speaker, and the last 30 minutes or so will be really a case-based discussion. So we encourage folks who are on the Zoom to actually participate in these discussions, ask questions, jump in, raise your hand, or ask to unmute so you can participate in these case studies. So we're looking forward to this first presentation with Dr. Shoptaw today. This series are every 2 weeks, so we will have another session in 2 weeks on Friday at the same time. So we're looking forward to this first session, and then the next sessions will follow, and we'll send correspondence about that. So without further ado, we are 3 minutes past the hour. I'm going to go ahead and welcome Dr. Julio Meza, who will be our moderator today. Dr. Julio, please go ahead and introduce our speaker when you get it. Introduce yourself and our speaker.
Definitely. Thank you very much. And thank you everyone for joining us today. And we're pretty blessed to have, and in my case, especially really honored to have this opportunity to introduce Dr. Shoptaw to kick pretty much this great project that, just to give a bit of background really briefly, is something that it came out of the idea of Dr. Shoptaw from our former fellows here in the Addiction Medicine Department in UCLA. They actually started with the planning, and now we have the opportunity to have this first meeting. And now, without further ado, definitely we're going to have as well our fellows present a portion of the topic today. But I'm going to introduce Dr. Shoptaw first, okay? And Dr. Shoptaw is someone who has been pretty on the field for quite a bit of time, and a lot of us, we've benefited from his knowledge. He has been a participant within the Department of Family Medicine for the past 30 years, and a mentor to me ever since I joined, not just as a resident. Actually, it's a really interesting story. I joined as an international medical graduate, a program that also is unique to UCLA. And one of the individuals who has been participant of that program as well is who? Dr. Shoptaw. Then I met him as a resident. I met him as a fellow when he said, you know what? We have the need to treat addiction medicine here in Los Angeles, and UCLA should be at the forefront, just like what we do always. So I have, with great gratitude and honor, I want to introduce Dr. Shoptaw, who's going to speak for us today.
Thanks, Dr. Meza. And it goes without saying, you are awesome and our best and first addiction medicine fellow. So it's you set the bar really high. It's wonderful to be here. It's a bit daunting to be in this room. There's many of my peers from a while back, back when we started this work. It's great to see everybody. Also, I just want to point out that this is a really important day for me in the sense that we started the Addiction Medicine Fellowship with the idea that we'd be doing something big. This is a fellow concept. This isn't something that I pulled out of my head. This is something that the fellows said they want to do, and the fellows will be featured today. So I see this as a capstone for our fellowship here that we've reached this day, of which Dr. Meza is an important builder toward this point. So it's a partnership between the research and the clinical aspects going on. And it really is a marker that we are pushing our influence and trying to move treatments further out in the community. And, the other part about this is it's very important is the issue of the personal aspect of this. So that's why we're talking about patients. I'm going to walk through data. Some of it you've seen before, that'll go quickly. But we're going to move to case-based strategies because we want to have a conversation I'm going to stop talking because we need to get through to my stuff to the peers, to the patients. Let's get started here. So we're talking about medications for evidence for stimulant use disorder. Next, am I on? I don't have control. Next slide. Here are our disclosures. I have disclosures here from Alkermes, Indivior, and Gilead, and I also do some consultation to ALS and Clear Scientific. Next slide. So here's a poll. Which of the following medications has an FDA approval for treatment of cocaine use disorder? Dami, okay, great. And which of the following medications has evidence for treatment of methamphetamine use disorder, but is not technically FDA approved for this use? So if you can vote your conscience there. In the first one, there are 5 choices, and in the bottom one, there are 5 choices too. So you may have to scroll up to answer the second question, or you may not. Okay. All right. Dami, what do our results look like? Do we know, or do we just move on?
We have 39 participated. I can end it so we can see the results. Would you like to do that so we can move on?
That'd be great. Yeah.
All right.
Oh, I just see my results. I don't know. Do you see results?
Yes. It says I'm sharing, but if it's not,
Okay. Yeah.
the first one is none of the above.
Okay.
And the second is A.
Mirtazapine. Correct. Yes. Okay, great. All right. Let's get started. Next slide. So we're going to talk about today the proficiency in culture, epidemiology, and common comorbid conditions, always going back to the fact that methamphetamine in particular has a place in people's lives. We're going to understand the evidence for the medications, and then we're going to apply that evidence in terms of understanding how it works with real people who have a lot of complexity. Next slide. So starting with the idea about people who use this drug, we want, on the left side, you've probably seen parts of this that list the physical and psychological pluses and minuses of methamphetamine use. The other part of it is that methamphetamine fits within the culture of people's lives. Among gay men, it allows people to have sex, and a particular kind of sex that's not available to people when they're not using methamphetamine. Shift workers, to live in LA, it costs a lot to live here, so a lot of people work 2 jobs. Bikers and gang folks will actually get involved with methamphetamine for lots of different reasons, including selling the drug. Women like the drug and being able to continue to have all of their activities done, and actually be interested in sex when their partner comes home at night. And the idea here is about weight loss. Methamphetamine helps people to, continuing around clockwise, among people who are rural or youth who have a lot of time to sit with. It helps pass the time. And more recently, a real function of methamphetamine is among the homeless folks, because it allows people to stay up at night. So the drug actually serves a safety function by helping people to stay up at night when it's dangerous, and move on and sleep during the day. Next slide. The point about this slide is that across the country, the general population is still low of estimates of methamphetamine use, but among groups who are already using other drugs, methamphetamine is increasing. This includes people who are using heroin and other opioids and LSD. Next slide. This slide just shows you the current epidemiology data about cocaine, prescription stimulant use, and cocaine and stimulant prescription misuse. On the right, you can see that for the most part, people have allegiances to the drug that they use or the drugs that they use. And then you can see on the right, the really big risks are in the age band of 18 to 25. but there's still significant risks for stimulant use thereafter. Next slide. The co-occurring conditions here in Los Angeles County, I wish I had an archival picture of this, but I don't. It's from the HIV annual surveillance report, and showing the co-occurrence of syphilis, methamphetamine, and HIV incidents, new cases showing very high linkages between where HIV incident cases happen, where methamphetamine is, and where syphilis is. Next slide. So that comorbidity is a major point. But we also see here in the country, here are the 4 waves of the overdose crisis. You can see here that fentanyl, and with and without stimulants, that very steep curve on the right, showing the high rates of people dying from those drugs in combination or alone, and then seeing that the heroin and prescription opioids, actually incidence of death is decreasing. Next slide. Just continuing this point, just showing again, the blue on the bottom is fentanyl, the purple is fentanyl with stimulants, and the red is stimulants without fentanyl. So if you just look at those two drugs, two drug classes, you're looking at over 80% of people who are dying over time. Next slide. And the other part of it is we're going to spend some time considering the idea that regular use of high-dose stimulants is a major it's a major insult to the cardiovasculature. And here's data showing that we see increases in inpatient inpatient admission for acute heart failure related to stimulants. And you can see, again, just showing that same sort of arc up. These are the latest data. I would imagine that we would continue to see this increasing. And the reason is because one single dose of stimulants may not cause a heart attack or a stroke, but a year of high-dose stimulant use sets up the damage to the cardiovasculature. We'll talk about that some in the cases, and that can actually that actually results in what goes on here. Of course, if you don't use stimulants, you're going to be doing better things to your cardiovasculature, generally speaking. But we're talking about addiction, and addiction is continued use despite knowledge of negative consequences. Next slide. So what about medication for methamphetamine use disorder? There are no approved medications for stimulant use disorder. That's another talk. It has to do with the fact that we don't have a pharmaceutical company who wants to step in, because we certainly have data that could actually push some of that. And I don't believe that there will be an FDA approval for any of the medications that we'll talk about today in the next 5 years. But there is a small suite of medications that have strong evidence of efficacy, and that's why we're talking about this. This is really important to me and exciting to me, because after 30 years of research, I actually have something to say about a medication that can be brought into people's lives for helping them to get over, to resolve their methamphetamine problem. Next slide. We're going to spend disproportionate time to the medications that have strongest evidence of for use, and this we'll start with extended release naltrexone, every 3 weeks, injectable with bupropion, high dose, 450 milligrams every day, and then second we'll go into mirtazapine at 30 milligrams a day. Next slide. These are data from my one and only New England Journal paper with Madhukar Trivedi and the group at UT Southwestern, showing basically what happens when you do use this combination with folks with severe or moderate to severe methamphetamine use disorder. The number needed to treat here is 9. I don't want to spend a lot of time on the fancy parts of this, but it's a serial SPCD design, serial parallel comparison design, where you actually randomize in the first 6 weeks a 3-to-1 ratio placebo to active. You measure outcome in weeks, in the gray bar, that stage 1 evaluation period. That's weeks 4 urine tests collected in the last 2 weeks of that first stage. In the placebo condition, those who were not doing well actually were re-randomized 1-to-1 active to placebo. And you can see that from visits week 7 to 12, you can see again that rise over the medication combination over the placebo condition. And looking at stage 2, the evaluation period there, you can see that's a significant difference. The weighted difference between the two stages is 11.1 percentage points. I'm going to present some data that shows that you can only contribute data in a trial once. So if you were randomized to the active condition, where you see that nice pink bar going up, that your contribution to the evaluation was in the last 2 weeks there, and then we didn't follow you again thereafter. We've seen exactly what happened to those folks in weeks 7 to 12 in new data, and I'll show you that next slide. Here's what happens. So it's very fascinating to see. There's that same curve you see from weeks 1 to 6 that we saw in the prior slide. And if you looked at 7 to 12, that's the new data. We didn't see them in the analysis from the SPCD design. And you can see that there's increasing benefit to being able to provide methamphetamine negative urine tests from weeks 7 to 12. So and you can see there that the slope doesn't stop. So one question would be that we're going to be looking at is, does it have benefit to people to continue with this combination? Next slide. Jeremy Kidd, at University of Columbia did a secondary analysis of these data, looking to see if men who have sex with men and women, the gay and bisexual men, that's the top 151 there, versus men who have sex with women, that's 95, showed a difference in the response to the combination, and sure enough, they did. You can see that the treatment effect H in the red bar over there is about 15% for gay bisexual men versus 2% for men who have sex with women. We have no idea what that's about, and Jeremy has just submitted an R01, his first R01, to test prospectively this post hoc analysis to see if this is something that's real or something that's not. Next slide. So the findings are really important. It's the largest trial that's out there. We don't know what the signal is due in terms of efficacy. We see it's a very stringent design. We know that each of these medications may have an independent effect on methamphetamine, but the combination produces a synergized effect, and I think that's really important. Lower doses of this combination are efficacious for weight loss, some say. But the idea here is that idea of having that interaction between these medications is what may be most active. Next slide. The other option that you can go with that shows strong evidence is mirtazapine 30 milligrams a day. And these are the data, you may have seen these, Grant Colfax's trial, 12 weeks with men who have sex with men and transgender women, and published in 2011, showing about an 18% drop in terms of producing positive urine tests for methamphetamine compared to placebo. And then Philip Coffin, who replicated that trial, you can see I drew a blue bar there at 12, and you can see that the orange dots, that slope is about the same slope as what Grant published. Phil did this work, published in 2019, 2020. It's in December. But the major take home here is the number needed to treat is about the same as the combination. It's about 8. And the take home here is that instead of continuing to reduce positive methamphetamine in weeks 13 to 36, basically all the change happened in the first 12 weeks. So for mirtazapine, it seems like it's a medication that helps people to reduce their methamphetamine use in those first 12 weeks compared to placebo. But then you've really sort of hit the asymptote, and there's not much more benefit after that. Next slide. A meta-analysis of the two trials show a significant effect in the top diamond there, showing the plot and the meta-analysis of the reduction of methamphetamine positive urine toxicology screens at 12 weeks with non-significant outcomes for retention in treatment or reduction in depression, which is kind of interesting because mirtazapine is an approved antidepressant. Next slide. So the question is, what is going on in terms of mirtazapine and working in its efficacy for methamphetamine? The excitement that I have for mirtazapine 30 milligrams is it's really hard to do the same thing twice in science. It's like almost impossible. So this replication showing the similar effect really gives me some confidence that that's a medication signal. I have no idea. We know for sure it's not antidepressant. It's not functioning as an antidepressant to change people's methamphetamine use. More likely, the mechanism is restoration of the sleep architecture. People who use 30 milligrams of mirtazapine have demonstrably better sleep during the trial. It's measurable, and that sleep disturbance is also a common problem that leads people back to using methamphetamine, as well as the depressive parts of early withdrawal. So potential downsides, there's a weight gain that's significant. Some people have suggested going 15 milligrams as opposed to 30 milligrams, but in fact, that's the wrong idea because 15 milligrams tends to have a higher weight gain than the 30 milligrams. Some people have said you need to step up to 30 milligrams, which again is probably, there's no data that says that that's what you would do. In general, what you want to do is just start with the 30 milligrams. At least that's where the data are. Next slide. There is an ongoing replication study, a large replication study in Australia. Now, the really cool thing is there's an ASAM stimulant guideline systematic review. It's available for open comment, and you'll see the website where you can actually download your own version of this. But like I say, after 30 years, we finally have something to talk about, and that's what I'm going to talk about next briefly. I want you to download the stimulant guideline and look at it at leisure over the weekend. There won't be a test, but it's always good reading. Next slide. So this is just captures all of the evidence that we have that have for medications that have weaker effects. And this sort of lists them. You can see I have these tabled out. You can download the table, or you can take the stimulant guide and read it. I'm not going to go through these, but basically the bottom line is whatever effect is in here is weak and inconsistent. So bupropion, which is part of the combination approach, has very inconsistent effects on its own. Sertraline makes you feel worse. Atomoxetine has a weak signal. Aripiprazole makes you worse. Methylphenidate actually can help you do a little better with your methamphetamine use. Topiramate has a little bit of a signal for reducing methamphetamine positive urine drug screens at 6 but not 12 weeks. And again, we get into this weak effect stuff. Oxytocin reduces symptoms but not drug use. Next slide. There's a couple studies on D-amphetamine, which reduce amphetamine withdrawal issues, complaints. Methylphenidate is another stimulant that actually also breaks out and actually does reduce methamphetamine use in secondary outcomes at 12 weeks, and also increases retention at 6 weeks and reduces craving and fewer methamphetamine positive urine drug screens. So there's a signal here for stimulant substitution. I know we don't like to use those words, but that's something to think about in terms of medications. Modafinil, no consistent signal. The strongest significant signal for reducing methamphetamine use is ammoniptine, which was taken off market. Again, it's a very powerful stimulant on its own. Next slide. GABA and opioid medications, there's basically nothing here to look at. Let's move down. You can see here the extended release naltrexone has 2 trials showing no effect on anything. The 1,000 milligram implant, no effect. There is a small effect of 50 milligrams per day of methamphetamine in reducing urine drug screens on the first trial that started the interest in naltrexone as a methamphetamine treatment a while back. Next slide. These are the other medications: ondansetron, varenicline, rolazole, N-acetylcysteine, prometa combination approach, transcranial direct cranial stimulation, and then there's nothing much there to pay attention to. I do want to point out that in a meta-analysis of antipsychotics, olanzapine and quetiapine are preferred for their antipsychotic effects, but they have no effect on methamphetamine. Next slide. By the way, that Seafried analysis is really good. Michael Lee and I published a clinical review on using some parts of these medications that have a stimulant, a signal in terms of reducing aspects of withdrawal symptoms. You can download this and see, but generally speaking, ammoniptine is the only medication that shows a strong efficacy signal for withdrawal symptoms. We talked about how that's already been taken off market. There are inconsistent signals for other treatments for methamphetamine withdrawal, and you can make some arguments for using them. And I list some of the symptom relief medications that have some of the better databases for mirtazapine, the combination of naltrexone and bupropion, repetitive RTMS during the first week of withdrawal seems to help reduce symptoms and late protracted withdrawal phases. There is an ongoing study right now in Australia looking at high dose for amphetamine withdrawal using high dose Lisdex, starting at 250 milligrams of Lisdex amphetamine and then reducing 50 milligrams a day to end at 0 over 5 days. And that seems to be helping people to stay in hospital and to complete withdrawal and then move forward. So stay tuned. There'll be more on that. Next slide. So here's where we get into sort of incomplete response, addressing cardiovascular insult in people who use methamphetamine. We showed data that shows that this methamphetamine use causes cardiovascular insult, and that leads to increases in hospital for cardiac disease. Methamphetamine is causal in 50% of cases with pulmonary arterial hypertension, and it raises the question. Philip Coffin is looking into this clinically in San Francisco, and I would encourage us to think about this. It raises the question of using statins in people actively using methamphetamine to protect the cardiovasculature. Next slide. So the summary that we've talked about so far, just click through here. These ideas present evidence to consider medications a foundation of treatment for stimulant use disorder. Next slide, next click. So click. We don't have an FDA-approved medication. Mirtazapine has strong effects. Click, because it's a replication. We have a large trial of extended release bupropion, extended release naltrexone and bupropion for reducing. Click. Other medications with mixed mechanisms have little signal, and there's strong evidence for use of antipsychotics for people with psychosis symptoms. Next slide. Some evidence of symptom relief for medications being used during the withdrawal phase. And next slide. This is the foundation, and you can see that a foundation is not a house. It really is the place where you start to treat. Is you start with a medication. There's some evidence here now to start thinking about building a treatment plan that includes a medication and a lot of other stuff to be able to help people, the whole people that we see, be able to address their stimulant use problem and their comorbid conditions. Okay, next slide. I think, and here are my references. I think at this point, I want to turn it over to Dr. Meza. Next slide, you can click through here. There's a lot of references, sorry. Keep going. Okay, one more, there we go.
Beautiful. Thank you very much, Dr. Shoptaw. We really appreciate this overview about medications. I know that it's a passion of Dr. Shoptaw, trying to find the best way to treat our patients with methamphetamine use disorder. Pretty much it has been quite a lifelong journey for him. And, you know, I'm glad that some of these research has produced results, right? And we can apply this clinically. And that's why now I'm going to give the floor to our current fellows, Dr. Jessica Wang and Dr. Giovanni Cruz. They're currently in our fellowship in addiction medicine here at UCLA. And we're going to try to do this as interactive as possible, in which we're going to present a couple of cases. And even though we have therapeutic options, there is a lot of questions when it comes to methamphetamines. We may not have all the answers. So that's why we're going to try to make an open forum for ideas to flow. Try to destruct these cases as much as you can, okay? And try to pretty much give us as much feedback in regards to the options that we propose, based on your experiences as well, because that's the only way in which we learn, okay? So without further ado, I'm going to allow Dr. Cruz and Dr. Wang to proceed.
Hi there. My name is Giovanni Cruz. I'm one of the current fellows, actually former UCLA IMG program alumni as well, and family medicine trained here in LA. So, and currently UCLA addiction medicine fellow. So this is the area that we have actually like poor research, right? Like we need to learn more about this every day because we've seen like patients, young patients, old patients, different socioeconomic backgrounds. So I believe this is a very important, topic, and I'm glad that we already like developing this foundation. And of course, the research is part of one of them. So I want to talk about the first case. In this case, for a 46-year-old female with a past medical history of a sedative use disorder. The patient also has a severe opioid use disorder that we call an early remission, and a severe stimulant use disorder that is presenting today due to a recent relapse. The patient has been using Xanax bars approximately 2 to 4 bars per day, with each possibly containing 2 milligrams, with her last use being about 2 hours ago. Additionally, she has been using meth through inhalation and also smoking, and with her last use occurring like 30 minutes before she was presenting to our setting. She is displaying erratic behavior, reporting anxiety, auditory hallucinations, paranoia, and irritability, which prompted pretty much like the evaluation. The patient also endorses that her sleep has been disrupted and she hasn't slept pretty much like for the past 3 days. On initial evaluation, patient endorses mistrust actually from the evaluator, think that she's at her aunt's house, and pretty much is questioning our presence, or and it's difficult to be redirected. So as far as we know, there's no history of bipolar disorder, there's no history of schizophrenia, and no previous history of psychosis. But she has been presented with erratic behavior under the influence. This is per relatives. There is a history of generalized anxiety disorder, PTSD, which the patient takes clonazepam, although no records have been found on PDMP. Next question, next slide. Okay, so on exam, so when we see this patient, of course, like we evaluate vital signs, but also like pretty much like the whole comprehensive assessment, right? First hand, we can see the blood pressure is pretty elevated, 178 over 104, with also like elevated heart rate, 108, respiratory rate of 22, and temperature 97.4. And we can describe pretty much, like it pretty much makes sense what she's presenting with like right now, with the speech, with his fast rate and rhythm, but normal volume. The patient looks anxious, but also like the affect is full range and congruent with mood at this point. The thought content, as we described earlier in the case, the patient has like some paranoia, but she's alert and oriented person in time as well. So, and the concentration is pretty much like decreased attention span, and as there is an inability to properly attend and answer like questions throughout the interview. So, next slide. As we can see, there's like some, factors that we have to take into consideration. And this is like, we're like, we can participate. You can definitely like leave like some comments in the chat or unmute yourselves. But basically, like, this is what we do in terms of like the management, right? Like the first question is, what will initial management be for this patient in the following settings? In this case, we're describing like the 3 most common that we'll see, which is the hospital setting, a residential level of care like 3.5 to 3.7, and of course the outpatient clinic, with additional questions in terms of like a stabilization for this patient, like benzos, using any type of like antipsychotics, and what about like the vital signs at this point, right? So I mean, we can just open up like right now, or whatever you guys, if you feel like you want to leave like a comment on the chat as well, that will be, highly appreciated. Let's see.
Do you want to go back? Can we go back a slide to just leave the case information up for folks while they come up with their answers?
That will be great. Yes. And as we can see, right, like in this case, our patient is presented with some sort of like a specific symptoms and signs as well. But based on the story, we have an idea what's going on, right? Maybe is the patient like presenting with some sort of like, like substance use disorder, like intoxication. We don't know if like there's also a component of withdrawal symptoms with the, other substances as well. So this is like pretty vague, right? But the point of this is, we can go to the subsequent slides. The subsequent slide, please. Yeah, so in the hospital setting, this is like we're like, addiction medicine comes into like pretty much the art and the resources that we have at hand, because obviously in the hospital we're going to have a lot of resources. We're going to have the ED, we're going to have the medications, we're going to have the personnel and the nurses to administer the medication. So that's the beauty. And like in terms of like a safe place to be, of course, like the hospital will be like the safest place to be, because we can take, immediate safety measures, like ensure that the patient is placed in a safe environment, right? We will consider like medications like right away in order to stabilize this patient. And of course, treating pretty much any underlying medical conditions contributing to the altered mental status, because at this point, we don't know exactly what else is going on. There is a comment on the chat if like the patient is capable of providing this information. Yes and no. As we could describe, like she was, like providing part of the information, but also like we got it from family members, relatives, and like I guess like other like personnel that was in contact with the person. But because most of the time these patients are actually brought in, they usually never present themselves, right? Like, hey, I'm in paranoia or in acute psychosis, right? So a lot of this information is actually gathered from like other like witnesses as well. At this point, what we try to do is also like the escalation as well, right? Any RX for other stimulants like cocaine, as far as we know, she is not positive for any of that. So in the next steps in the treatment, right, like the de-escalation, we always attempt the verbal de-escalation techniques to calm the patient, because otherwise, like we don't want them to be more like psychotic or irritable, because that's not only dangerous for the patient, but also for the rest of the medical staff as well, right? But the beauty is like in the hospital, we have all these resources that we can do. Of course, like thinking about pharmacological intervention, if the de-escalation is ineffective, and of course its safety is a concern, considering using sedatives, antipsychotic medications, and this is depending like, like second generation antipsychotics usually, and of course, like it depends on the hospital protocols as well. So consultation as well, like this is a, this is a great, thing that we can do, right? Psychiatric services, because this could be something related to that, okay? Anyone else would like to, like talk about any other like aspects that you would like to do, would like to order? How would you like, manage this patient?
Yeah, I see one of the questions there, Dr. Cruz, is how would you handle this patient? Let's say, would you give us an example on what you will do? Let's say in our headquarters here in Santa Monica Hospital, how would you handle someone who presents like this?
Yeah, well, that's a great question, right? So this is where like we do the more comprehensive assessment, not only a psychiatric assessment, but is this truly related to a substance use, right? Because at this point, we have enough information to suspect that this is related to substance use, especially like meth, or maybe something that meth-induced psychosis. But I guess, am I biased because I'm doing addiction medicine, right? But we always make sure that we have the proper information. In this case, a UTOX, a CBC, a CMP, imaging as well, because we don't know if this patient is dealing with some other conditions as well. We don't know if this patient is taking other medications, interacting with like some substances that this patient has been used. So what I would probably have done is obviously like the immediate safety measures, medical stabilization with antipsychotics, probably de-escalation of the situation as well, the pharmacological intervention as mentioned, and obviously like this, the concurrent consultation with our psych colleagues as well. And of course, like trying to follow up as much, as we can, the legal considerations of this, because sometimes like we have to, this is a balance, right? That we have to document pretty much everything, like the assessment, interventions, the patient behaviors, accurate and thoroughly as well. And of course, like this, always in compliance with laws regarding the involuntary psychiatric evaluation and holds, because we don't know if this patient is actually threatening like himself, like or others. So it comes a lot, and this is the point that I wanted to mention in terms of the hospital. Since we have all these resources, we can do and order like these exams just to try to corroborate from the clinical part, right? If you're suspicious of like something related to substances, we need to analyze first, like what kind of substance like the patient has been exposed to, like and of course with the objective data, which is positive UTOX for something or something else related to that. So this is probably.
There's a question in the chat about, are most or all these tools available at the outpatient clinic? Thank you, Lincoln, because that's exactly the point that we're trying to hammer here. Gio just listed a whole bunch of things we can do in the inpatient setting, but because it's the hospital, we have everything.
I know.
I'd actually love to hear from, I think we have a number of folks from residential places.
Yeah.
If this was a new admit to your residential, what would you do differently? Or what could you do based on the setting that you have?
Yeah, anyone who has worked in the past or currently in a residential level of care 3.5 to 3.7, let's say this patient shows up to our, as we call them in the community, detox, right? What can we do there? Do we have the resources that some occasions we have at the hospital? Do we have anyone with such experience?
Yeah, please feel free to raise your hand, leave a comment on the chat. Just that, for like the other attendees that we have, like what is a level 3.5? What is a level 3.7? Right, like the 3.5 is clinically like managed residential services designed for people with serious, like pretty much psychological or social issues. They need like 24-hour oversight. 3.7, of course, is a little bit more elevated.
So Dr. Cruz, given that no one's answering questions right now,
Yeah.
would you actually talk about like your thoughts about managing this case in terms of medications, either in a residential or outpatient setting? Like, would you use an antipsychotic? Which ones would you select? And George Woody has his hand up. George, you want to?
Yeah, I just comment about resources. One thing we don't have in the U.S. is, or we don't support very well, in most cases, is long-term residential treatment. Or we did a Vivitrol study in Iceland, and they have a treatment system that's different than ours. And the results, it looked like the psychosocial treatment had a substantial effect. The patients, it's a national healthcare system, it's a small country, but there was clearly a stimulant problem. It was primarily methylphenidate, I believe, is doctors were prescribing it. And everybody who applies for, there's a central hospital, everybody gets admitted for 7 to 10 days for a medical evaluation, and then they go into a 1 month intensive residential treatment or intensive outpatient program for a month with follow-ups continuing. And the treatment's oriented toward like combination of cognitive therapy and 12-step. And the urine results in that were our statistician was used to looking at analyzing results of a lot of cocaine treatment studies. And he wondered if the patients were really drug addicts because such a high proportion of them had negative urines over, I'd have to look at the paper again, over an extended period of time. So I just think we need to I just would like to make a point about the evidence of psychosocial treatment, because what I saw in our study in Iceland was their psychosocial treatment was long-term, and it was part of a national healthcare system, and the results were a lot better than any of the cocaine treatment studies and stuff that we've done here. So, but we have a different situation here, but the medication effects don't seem to be real strong when they're there. And but we didn't have a naltrexone effect, but I think it's because naltrexone, if it has an effect, it's not a very strong effect. But the psychosocial treatment did look at had a very strong treatment. Anyway,
very interesting, because actually yesterday I was having a conversation with another addiction psychiatrist, and he was mentioning that, like, pretty much in Europe, for some psychiatric comorbidities, we tend to like back off a little bit more on the medications, and they emphasize a lot in therapy and psychotherapy and other like methods that is not related to drugs. So it pretty much like echoes what you're mentioning right now.
And so, Richard Cortez wanted to give a contribution as well of knowledge.
Yeah. In Iceland, employers will send employees with drug problems. Alcohol has been traditionally their main problem, and they'll send them to treatment, and they'll expect them to come back in much better shape, and they rehire a lot of them. I was told. We didn't have data on that. But,
yeah.
Yes, Richard.
Yeah, I've worked in detox residential outpatient for the last 20 years, and things have changed the way treatment is. But I also like to, like, when we first get a patient, is look at any medical history we have, any psychiatric history, and wait for the urine samples to come back to see what the methamphetamine might be cut with to cause the psycho or whatever mental health wakes it up, or if there's any THC that wakes up mental disorder, so I can have a better view of what I'm working with. That's been and then I get the proper people who's their scope to do that, and I call them in and do evaluation in the team meeting, and where we go with that participant at that time. That would be what I would do.
Yeah. Oh, excellent. And it comes down to triage, right? So definitely really great points, everyone. We're going to try to move to the evidence on the medication we spoke before, but basically what I've seen on the chat, all of us, we gave contributions and we got to really cool answers, right? Like if we see someone like this in the hospital setting, right? First, stabilize the patient, right? Let's look at those vital signs. We need to think, as well mentioned before, right? Is it benzodiazepine withdrawal? Is it methamphetamine-induced psychosis? Are we facing a point-blank hypertensive emergency, right? What are we going to do at the end of the day, right? If the patient is behaving erratic, the use of antipsychotics is possible. Maybe benzodiazepines preferred if you deem that the patient also is withdrawing from benzodiazepines, right? And definitely proceed with the algorithm to treat the hypertension as well. Residential level of care, I think someone mentioned there in the chat as well, right? Is this a patient who's deemed to be fit to be admitted to this facility, or do they need to be cleared by a hospital and stabilized before engaging to treatment? That's key, right? Similar to an outpatient clinic, can I handle this, right? And someone really nicely also mentioned about a homeless shelter, right? What would we do there? We can offer them Seroquel. It is possible, definitely, right? And definitely as well, something to treat hypertension. And as we gain their trust by us offering medications for that symptomatic relief, more likely they are to come with us and say, you know what, it's helping, but not as much. Definitely my life is in danger based on my symptoms. I'm going to go to the hospital, okay? Can we go to the next slide to go over the next portion of the depiction of the medications that we can use? So sorry, Dr. Cruz.
Yeah, no worries. Yeah, obviously for sake of time, like after a few days, our patient went into a safer taper withdrawal benzodiazepines. Now the patient is endorsing hypoactivity, and anhedonia now endorses that he's craving meth. After explaining the benefits and risks, decided to start with off-label use of bupropion and long-acting naltrexone. So what diagnoses are this medication approved for? Both of them, naltrexone or Vivitrol and bupropion. And we just, that was pretty much mentioned on the slides a few minutes earlier. Perfect, right? So not a tricky question. So with bupropion, we most of the time, like, we prescribe this medication for our patients that like have some sort of like depression or some other comorbidities. We also like use the medication for smoking cessation as well. So it's in theory, it's not a hard medication to prescribe, right? It is a little bit different with naltrexone, because the long-acting naltrexone, especially if you do an ICD code with a stimulant use disorder, cocaine or methamphetamine use disorder, regardless of the severity of it, earlier remission or not, it is probably not going to be approved. But the way around this is that what we actually seen in practice is, if we ask the patient, have you ever like, do you drink, or you have a history of like alcohol use? And if we can label that medication under that, it is more likely to be approved by the insurances, right?
Someone asked, how about the sedative use disorder? Is it approved for that?
No, it's not. We don't have any approvals, unfortunately, like for sedative use disorders for benzodiazepines, but that's a great question too. So how can we obtain these medications for our patients, and how the coordination actually like happens when we receive Vivitrol? So we all been in, in this game with insurance and PAs and all of that. So this is kind of like convoluted, but basically like we have like different approaches depending actually on the type of like insurance or like the coverage that the patient has. Like usually with medical, and this is like very easy and for injectables. So for example, other like treatments like hepatitis C, rheumatology medications, it is fairly easy because they usually do not require any PA authorization. So once we order the medication, especially like to the pharmacy, it depends on the pharmacy, of course, they will deliver the medication, and we can start, the treatment. But it is slightly different with other plans like managed care, HMO, PPOs, and some HMOs as well, because once we order the medication, it has to like pretty much go through like one of these like two parts, right? Is this like a pharmacy or a medical benefit? What we do most of the time at UCLA is just to like usually pick one. Most of the time we do pharmacy, because if it's denied, that is pretty much implicit that this is going to go towards the other one. The medical benefit is the one that's going to be approved, right? And we try to avoid like this like game, like, okay, let's do like medical this time or pharmacy, but also it depends, because sometimes these insurance companies, especially when we call them, like they might have a specific contract with a specific pharmacy, let's say like some names like CVS, Walgreens, you name it. So we have to go towards that as well. But with this type of coverage like PPO and some HMOs as well, sometimes we need this PA authorization, and that's why we need to submit it. Here in the community, especially at UCLA, we have our dedicated pharmacy near the hospital, right, that we can order, and sometimes they deliver, like sometimes the courier services are not great, but this is where like you need to find in your community the pharmacy that suits you, you can have like a great communication so they can deliver these medications and promptly to your clinic, so you can administer to your patients, especially like the Vivitrol. And once you have that, like we can administer it and smoothly treat our patients. So next slide.
We have a really good question here on the chat as well and they mentioned, right, that most of our patients admitted for stimulants, also they end up testing positive for opioids, whether it's knowingly or not knowingly, okay? And this has become quite a big issue. Can you talk about that as well?
Yeah, we've seen that actually with some of our patients. And I mean, this is like pretty much like what we see in terms of like documentation as well, because some medications, for example, and this is the case, for example, with methadone, right? Like you don't have to be a designated federal facility for methadone if you're dispensing it for pain. But if you somewhere in the chart you put an opioid dependence or something like that, the likelihood of being denied is actually higher. So as far as I can see, but of course, like I don't have like enough experience in the field, right? But I haven't seen any issues with like opioids, like positivity in this case with patients. I haven't seen a denial so far, but like, I mean, I don't know, like if like other like, participants have seen something,
how will this modify your treatment plan acutely? I think that's what they're referring to.
I mean, acutely, like it shouldn't like modify like much, because at this point, once we are past the acute phase of the treatment, we go into the maintenance, right? And based on like the evidence that we have right now, like in the studies, like the one that Dr. Shoptaw was mentioning, I think in this point, like classified as an opioid use disorder, or even like have like that idea, I don't think that will modify, obviously, but of course we need to determine based on the criteria that or DSM-5 if this is actually, or like the positivity as well.
There is the caveat, though. I think maybe what Daniel's getting at is that naltrexone, you obviously can't use that with buprenorphine if you were to try to use that for medication treatment of OUD. You can use naltrexone by itself to treat OUD.
The problem,
you could do that, certainly. But you know, if you compare the two, as we all know, if you compare naltrexone versus buprenorphine, there just tends to be more fallout with naltrexone. So that would be the one caveat that maybe we're trying to get at with trying to do opiate use disorder treatment with methamphetamine use disorder with this specific combination of medications.
Yeah, but
now sort of alluding to the other set of medications, the mirtazapine, that shouldn't be any issue to combine together with medication treatment for OUD.
And also because with Vivitrol, with naltrexone, we have this warning, right, that we have to be free of opioids for 7 days. So I guess it comes like, I don't know, like in the clinical picture, like, well, is this like a really positive like opioids? Maybe a confirmatory like lab testing will like give us like more answers. But I guess and sometimes, because we've seen, right, like meth that is laced contaminated with fentanyl. So I will like probably like maybe hold off like and the naltrexone, at least in this case, for example, for this patient, until we have like 100% sure like information that she is not using any other opioids, or the meth that she was using, it wasn't contaminated with fentanyl. So
Dr. Mesa, I know we're running really low on time. Do we want to just dedicate the rest of the time to wrapping this discussion, or do we want to highlight the points we were trying to get to with the second case?
No, we can wrap up. Definitely, we may be able to continue in a future session, okay? The only question that I have, okay, because I see Dr. Weaver and Dr. Janeway as well, and then we wrap up, okay, is that I received a text from, and just to give context, these are two important integrants of the UCLA Homeless Collaborative. And this week, someone from the team asked me, as they were providing care to the homeless, that there was someone who was using both methamphetamines and opioids, and they had the desire to implement some of what you just described. But they were asking, because the last use of opioids was 2 days ago, if it's okay to start bupropion now, or withhold the whole treatment until the opioids are kind of clear out of their system.
Well, that's a good question too. I guess, I mean, that comes into like, is the patient like stable enough? Like, if we're gonna keep monitoring the patient, right? Do we think this is gonna be safe to start? Because obviously, like, this is the legality of it, right? If we start a medication that technically is contraindicated, or has like a warning to use with opioids, we have to be really cautious about that. So I guess once we have like more information in terms of like the actual use of opioids, I mean, this is what probably I would personally do, like maybe hold them until like, we see more stable, try to like provide the best care for the maybe the vital signs, or stabilize the patient in general. And then once the patient is able to provide more information, which is usually like a couple of hours after, like, yes, have you used this? Have you been exposed to, like, or, like, gather a little bit more information, would be more prudent to start like something like that. But I mean, it is difficult to answer.
Not a problem.
I don't see why not. Because bupropion by itself, I mean, Dr. Shoptaw showed that by itself it maybe won't do a lot of benefit, but combined with naltrexone, hey, if you give it some time, maybe the patient can get used to bupropion first, and makes it easier to then also just get on the Vivitrol later. I don't see why not.
Okay, yeah, fair enough. Just let's make sure that we assess for risk of seizures. So so definitely thank you everyone for participating today. We finished just on time. Okay, my apologies because we extended, but it's a really cool discussion, right, on things that we know about these treatments, and definitely has been a pleasure of just looking at all the questions that you had, right, depending on the setting where we work. So we really appreciate your time today. Feel free to send us any questions that you may have. all of us were really easy to contact, and we're more than happy to answer those. I'm going to let Yemi to finish with more indication on CME and all that. Thank you.
Thank you all for joining. I'm the spotlighter and I can't seem to find myself. All right, thank you all for attending. Thank you, Dr. Shoptaw. Thank you, Dr. Cruz, Dr. Wang, and Dr. Meza for this great discussion. I'm not a clinician, but I'm sure that a lot of the folks who are working in this field had a robust just time with knowledge that has been shared today. So we will be sending out the evaluations to folks via email. Some folks have asked me for slides. The recording and the slides will be provided post-lecture sometime next week, and we'll send out an email as well. So please look out for that. If you're requesting CMEs, please go ahead and also look out for an email with instructions regarding that. The next session would be on November 3rd, and that will be presented by Dr. Clark. I'm wondering to see if I can share that real quick. So he will be doing the next session. The next session will be HIV, STIs, and stimulant use among sexual and gender minorities. So please go ahead and tune in 2 weeks. We'll send out an email reminder. Thank you and have an amazing day. If you have any questions, please feel free to email them and we'll forward them to our speaker and presenters. Thank you again and have a great day. Thanks for coming.